Okay, I have the distinction to say good evening to you all, and at the end of my talk, I can tell you good night. And I would like to thank all the people who are inside the hall. I hope you are not waiting for your chance to speak. Having said that, my thanks to the organizing committee of Diabetes India 2015, especially Dr. Banshi for having put me here, and Dr. Hardik to have brought me physically here today to speak to you people. And what's happening with my slides? They're not there. This is it. Okay. Before that, let me tell you, my predecessors have given you extreme amount of scientific talk, and I'm reminded of a real life concept of an engineer versus a mechanic. You know, this engineer got a gold medal from the university. His father gave him a very nice car. It broke down in the middle. He opened the bonnet, he couldn't make out what's happening. And he looked around, there was a mechanic, he brought him, and within a few minutes, it was fixed. And engineer was surprised and he asked the mechanic, how did you do it? The dour-faced mechanic said, look, I only fix them, I don't explain them. Now, my role is to fix what's happening and not to explain what's going to happen or what has been happening. And rationale for triple drug regime, when I was asked to speak, when Dr. Banshi asked me to speak about this, we were unable to, interact for a longer period because he was pretty busy. And I was not very sure what I'm supposed to speak about, whether we should use multiple drugs in type 2 diabetes or we should use a fixed drug regime in type 2 diabetes. Can I give you a... I have already given. Anyway, I thought, let's not digress from the concept, and said, we are probably looking at FDCS, fixed drug combination, or probably flexible drug combinations. The fourth one, yes. Okay, and one more disclosure I would like to tell. I remember I teach my postgraduates to use proper slides, and the simple concept is use dark letters on a white background. But to commemorate my own stature, I always use a dark background and a white lettering. So I usually wear a very light color shirts so that I am visible. Okay. My conflict of interest, none. Now, you all know why diabetes is going to be a problem in India, everywhere in the globe. And you remember DeFronzo, he started telling us in very flowery language, but an extraordinary science man. You had triumvirate and you have ominous octet. And now you have so many pathophysiological concepts of type 2 diabetes. For that, you are also adding the new concept, Dr. Sanjay Kalra, who started Dirty Dozen, vitamin D, RAS system, dopamine and testosterone. And in the recent times, especially GDM, you have treacherous 13, high iron intake or high hemoglobin during pregnancy. So if you have so many pathogenetic mechanisms that can make any one of us in the hall, whether we eat carbohydrates or not, to develop type 2 diabetes, do you have one size that fits all, as Stefano Del Prato said? Do you have one size that fits all in diabetes? That's the concept. That's where we start. And down the road, for the last 2 decades, you have so many guidelines coming. And one of the very, very comfortable, flexible guidelines, if you ask me, was AAC, where they not only looked at a magical figure of 7, they also gave a flexibility of HbA1c. They looked at flexibility of the drugs that you use. When you look at that monotherapy, dual therapy, triple therapy, 2 to 3 months at a difference, there is nobody who can refute multiple drug therapy in type 2 diabetes because of multiple pathogenic mechanisms and down the road beta cell failure. Different combination therapies on reduction HbA1c, if you look at meta-analysis, you need to use multiple drugs, dual, triple, or many more, to achieve the so-called magical figure of 7. And this is what's happening. What does it mean to find perfect balance? As a practicing physician who does not have too much of time to delve into a lot of science that is happening every day, million or so journal activities per year, what does it mean for us to find a perfect balance when we are confronted with the type 2 diabetic who walks into your clinical practice, sits in front of you and asks you a question, should I take or not? It's the question. The pragmatic argument that I can give you here is in 3 concepts. Early and optimal control of glycemia. No wait and see policy anymore in type 2 diabetes, we all agree, right? The need for multiple drugs. You have no other choice if you have to put them within 6 months or whatever time period you and your type 2 diabetic decides to bring their HbA1c down to around 7, you need to use multiple drugs. And the inability to achieve desired glycemic goals due in part to poor adherence to therapy. If there is more number of drugs that are going to be used, it's not just the cost that makes a type 2 diabetic not take tablets, it is the confusion. 3 tablets in the morning, 2 tablets in the afternoon, 4 tablets in the night, 1 before breakfast, 1 after dinner. God bless the patient. In fact, the doctor sometimes gets confused. I get confused whether I have told the right thing to my patient. So these 3 are the pragmatic argument that says you need to bring in fixed dosages or fixed drug combinations. Management of diabetes and abnormalities increases the pill burden. This is one simple argument that I am trying to give you. Simple concept is, patients have an average pill burden of 8.5 at A1C of 8.6. Not mine, already available data. Average pill burden gets increased to 13.1, A1C of 7. Question ever, don't ask me why 0.1 came. Are you going to break 1 tablet into 10 times? We will not worry about that. Okay? And you know all those statistics, 37.9, 79% antihypertension. The bottom line is, if you have to prevent cardiovascular risk in a type 2 diabetic, you have no other choice but to give few drugs for diabetes, few drugs for hypertension, few drugs for lipids, etc. At the end of the day, they are on so many numbers. It again makes sense to have fixed drug combinations. Poor adherence. If there is more number of tablets, they don't take it properly. Inconvenience of administration and remembrance. As I was telling you, it's always a big problem for old people like us to remember so many things in life. Increases in cost therapy. Negative psychological impact. When they are taking so many tablets, they get a feeling that they are not healthy enough. Even though they are doing best that they can in their life, they have a negative impact on their life itself. So, walks in the fixed, which started as fixed drug. Nowadays, you also have flexible, 0.5 mg, 1 mg, 500 mg, 850 mg, 1 gram. You know the story. Management of hypertension, dyslipidemia, acute coronary syndromes. You already have fixed or flexible drug regimes which are already in place for many number of years now and may improve medication adherence and compliance. Mind you, may improve. It's not will improve. It's just that we are taking baby steps for the last few years. It may improve medication adherence and compliance. Are they very effective? Only time will tell us. The initial combination therapy. This is what the final peg I'll have to tell you that has to be put, not a square peg in a round hole. It's initially. It's not 1 tablet, wait for 2 months, 2 tablets, wait for 2 months, 3 tablets like ACE of 2009 and later. It's initially would you like to use all the 3 drugs, all the 2 drugs, all the 4 drugs. That's the rationale that I feel would be very practical for a practicing physician. Early robust lowering of HbA1c, you can get their HbA1c down faster. Avoidance of clinical inertia associated with stepwise approach. Potential for early combination therapy to improve a big question mark beta cell function. Instead of beta, I have written a question mark there. Initiation with complementary mechanisms of action. You know, everybody has been talking, every drug that you use, whether it is a Sulfonylurea, metformin, they have so many activities. We cannot say pleiotropic, but multiple actions. Put them together, there may be a complementary action or synergistic. But the bottom line is, robust lowering of HbA1c you can expect only with initial fixed drug combinations. Potential to use less than maximal doses, which can probably translate into less side effect profile, probably. But having said that, I am not talking about theory. There is evidence-based medicine. UKPDS stands as one of the biggest, if I can say witness, to say that 70% of patients require combination therapy after 9 years. It's UKPDS 49. So you can imagine, if you start earlier, you could have saved them 9 years of misery. Achieve better adherence to therapy with fixed dose combination. 77% versus 54. Ask them to take 8 tablets or ask them to take 2 tablets. Adherence is better with fixed dose. So just to summarize or surmise, advantages would be convenience, ease of administration, ease of remembrance, efficacy, we were talking about complementary action or synergistic effect, tolerability and safety because of lower doses as whatever it is, and economy. This is one funny thing that happens in India. Fixed doses are probably a little bit less expensive than the individual drugs, which may not be true outside of India. And psychological. 9 tablets become 3 tablets in overnight. The patient feels better. Oh, I'm probably doing better. My doctor feels that I'm doing better. The last thing is, I was telling you, Stefano Del Prato, the global partnership recommends. If you look at the partners in this, it runs to pages. Okay? They say ideal components for combination therapy. You need to use the drugs that have complementary mechanisms of action. I'm not going to touch much on that, but you can all look into this reference. I think it's a very good read, if at all. When you are going back from Diabetes India, please ask them to give you a supplement and you can all go through it. It's a good read. But the last thing is what it means to find perfect balance. Just for the heck of it, this guy is trying to play drums and whatever, trying to balance himself, just for the heck of it. Do you want to do that? Just for the heck of it, oh, you want to take away longer time of discussion with the patient, you want to put them on fixed drug regime, or is it a life for the patient that you have to look at? So it makes a great sense. If you can take care of your patient's component and not the doctor's component, it makes great sense. I'm sure you all, I'm sure know these 2 people, right? Okay, Einstein and Rabindranath Tagore. But what happened, a literary giant and a scientific giant, if you put them together, imagination is more important than knowledge. Ladies and gentlemen, no amount of your science will help you to do better to your patients. Please have a little bit more of imagination so that you can do better. Thank you.